السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله. صوتي واضح؟
أيوة واضح صح.
تمام.
طيب، بسم الله الرحمن الرحيم. أولا، أهلا وسهلا بكم جميعا. نبدأ أول محاضرات كلينيكال نيورولوجي سمر كورس، المقدمة من نادي المخ والأعصاب بجامعة الملك عبد العزيز. المحاضرة حتكون بعنوان General Overview of Different Types of Weaknesses, Upper Motor Neural Lesions and Lower Motor Neural Lesions. يقدمها الدكتور عمر بخاري، طبيب مقيم في تخصص المخ والأعصاب، المستشفى الملك فهد العام جدة. طبعا لا تنسوا برضو ننوه على أنه ملء استمارة التحضير اللي أرسلنا لكم إياها بالشات، والأسئلة بإذن الله حجاوبكم عليها كلها في الأخير، يعني يفضل تخلوها في الأخير. تفضل دكتور عمر.
يزيد فضلك. طبعا زي ما قال زميلي إن شاء الله حنقدم محاضرة الويكنس. طيب, our objectives for today's lecture, we will recognize a possible localization for weak patients, differential diagnosis based on localization, determining the cause of the weakness, mention brief important history taking points to determine the pattern of weakness, and how to differentiate between upper and lower motor neuron through examination, investigations, and finally with the case. So in the beginning we need to define weakness. Weakness is defined as loss of power or loss of motor strength. It is not hypotonia. Patients can sometimes describe their symptoms by weakness, although it is initially subjective. So we need through examination to determine is it really a weakness or, for example, it could be due to pain. The patient cannot walk due to pain. That's why he's saying he's weak. So like I said before, weakness can be subjective or objective. Subjective, it could be related to pain or any other non-neurological causes. For example, patients with rheumatoid arthritis or malignancies or fibromyalgia can say they are weak, although it is due to pain. So anatomical approach to weakness, we can define it as upper motor or lower motor. Upper motor consists of hemispheric or brainstem or spinal cord, and descending to the lower motor neuron, for example, anterior horn cell or neuropathy, periodicular neuropathy, plexopathy, distal neuropathy, neuromuscular junction, finally with the muscle weakness. What is the difference between hemiplegia and hemiparesis? Hemiparesis is partial weakness, and hemiplegia is complete paralysis. We have a lot of patterns of weakness. For example, hemiplegia, which is right side or left sided weakness. Brachial diplegia, it is bilateral arm muscles weakness. Facial diplegia, which is facial weakness. Monoplegia, which consists of unilateral limb, for example, right upper limb weakness or right lower limb weakness. Paraplegia, which is bilateral lower limb weakness. Quadriplegia or tetraplegia, it is weakness of the four extremities of the patient, bilateral upper and bilateral lower. This is the same slide. We can grade the muscle weakness based on the Medical Research Council scale that we all know. 0, it means no contraction. 1, flicker or trace of contraction. 2, active movement with gravity eliminated. 3, against gravity. 4 active movement, and it can be classified into 4 plus and 4 minus to differentiate, although it is sometimes can be misleading. Finally, with 5, it is normal power. So systematic approach to motor weakness progresses along an anatomical tract. Impulses are generated in the primary motor cortex map to the homunculus, then aggregates as they descend through the internal capsule. Fibers then decassate in the medulla and descend into the contralateral corticospinal tract. These upper motor neurons synapses with lower motor neurons in the anterior horn of the spinal cord. The lower motor neuron is bundled with neighboring fibers into a peripheral nerves and activates the target muscle fibers at the neuromuscular junction, as you can see in the attached photo in the slide. So this is an overview of motor weakness. We can evaluate weakness into distinct types. Upper motor neuron lesions, for example, lesions in the cerebral cortex brainstem, or descending motor pathway in the spinal cord. And we can call them also pyramidal tract disease. It can have long tract signs or central weakness. It causes increased muscle tone, increased reflexes, pyramidal pattern of weakness. For example, bilateral, or for example, drift. Type 2 lower motor neuron lesions, lesion of peripheral nerves and anterior horn cells of the spinal cord, also called denervation disease or peripheral weakness, causes weakness, wasting, fasciculations, decreased tone, and absent reflexes. Muscle diseases cause wasting, decreased tone, impaired or absent reflexes. Neuromuscular junction disorders, for example, myasthenia gravis or Lambert-Eaton disease, cause fatigable weakness, normal decreased tone. It has also normal reflexes. Functional weakness causes normal tone, normal reflexes without wasting, with erratic power. This table can summarize the different localization and examination. For example, in the upper motor neuron, we can have spasticity, no atrophy, although it can develop due to disuse atrophy with long time without moving the muscles. It can have sensory findings, for example, hemianesthesia, increased reflexes, and other findings, for example, Babinski in the lower limb or Hoffman sign in the upper limb. The first step in localizing the lesion is determining whether it is an upper motor neuron lesion or lower motor neuron lesion. The motor neuron pathway extends from the cerebral cortex through the spinal cord. Upper motor neuron crosses over to the contralateral side at the decassation of the pyramidals between the brainstem and spinal cord. Therefore, upper motor neuron type weakness can result from ipsilateral spinal cord lesion, contralateral brainstem lesion, and contralateral cerebral hemisphere lesion. And we can differentiate between these three as displayed in the table on the right side. In the cerebral hemisphere, patients can develop seizures, hemianopia, aphasia, regarding seizure, because the cortical surface in the brain can be irritated and they develop seizure. Also, hemianopia, if it involves optic tract or occipital lobe. Aphasia in the dominant hemisphere, inattention of body if it is in the non-dominant, aphasia in the dominant hemisphere. Cortical sensory loss, hyperactive jaw jerk. In the brainstem, we will find cross-motor findings, for example, contralateral third nerve palsy, and if it was in the midbrain, or contralateral sixth nerve palsy if it was in the pons area. Spinal cord, we will see sensory level, for example, the umbilical area down to the bilateral lower limbs. Pain sensory loss in the contralateral arm and leg. No sensory or motor findings in the face because it spares the face area. Additional lower motor neuron findings such as atrophy and fasciculations. lower motor neurons localization include
دكتور عمر،
أيوه.
إذا ممكن الشات طالبين إنك تستخدم الماوس. يعطيك العافية.
بس واضح الماوس؟
أيوه واضح.
طيب تمام. lower motor neurons, for example, the anterior horn cells, nerve root, peripheral nerves, neuromuscular junction, and muscle, for example, myopathy. Like I said before, myopathies, NMJs, for example, myasthenia gravis and Lambert Eaton, peripheral neuropathy, neurodegenerative diseases, nerve root reticulopathy, such as nerve root compressions, peripheral nerve trauma. Now we will discuss a little about weakness syndromes with the site of the lesion and what are the causes. For example, the unilateral weakness in ipsilateral face. Lesions can be in the contralateral cortex, internal capsule. It can be caused by stroke if it was sudden onset, demyelination such as MS or any neurodemyelinating disorder because of gradual onset. Symptoms can have neglect, visual field cut, aphasia, findings such as upper motor neuron signs. Key features associated with headache suggest hemorrhage or mass. The other syndrome, if it has unilateral weakness and contralateral face, the lesion will be in the brainstem, caused by vertebral insufficiency or demyelination also. Symptoms can be as dysphagia, dysarthria, diplopia, vertigo, nausea and vomiting. We will see in the examination as cranial nerve involvement, cerebellar abnormalities. Type 3 or syndrome number 3, unilateral weakness, no facial involvement. It can be due to contralateral medial cerebral cortex, discrete internal capsule, also caused by stroke. Rare causes can be due to Brown-Séquard syndrome, if contralateral hemibody pain and temperature sensory disturbance. Unilateral weakness, single limb, such as lesion in the spinal cord, peripheral nerve, neuromuscular junction. We will see upper motor neuron signs, also lower motor neuron signs, and it will be normal reflexes, normal sensation. Number 5, bilateral weakness of lower extremities, paraparesis and paraplegia. Lesions could be in the spinal cord, peripheral nerves. We will see upper motor neuron signs, which was, for example, the anterior cord syndrome, if it was due to compression, ischemia, or demyelination. Cauda equina and GPS. Bilateral weakness of upper extremities. Lesions can be in the center called spinal cord syndrome, caused by syringomelia and hyperextension injuries. Findings can be as pain and temperature sensitive disturbance in upper extremities, intact proprioception because it spares the dorsal column of the spinal cord. Number 7, bilateral weakness of all 4 extremities, quadriparesis or quadriplegia. Lesions can be in the cervical spinal cord. It can be due to severe spinal trauma or disc herniation. Syndrome number 8, facial weakness, upper and lower face. Lesion can be in the facial nerve, caused by Bell's palsy if it was maybe idiopathic or post-viral infection, mastoiditis, parotitis. Other cranial nerve, and it suggests brainstem lesion. The patient can also have bilateral weakness, proximal groups. The lesion can be in the muscles, caused by rhabdomyolysis, polymyositis, dermatomyositis, or myopathies. Findings: we will not see upper motor signs or sensory disturbance because the localization in the muscles. Bilateral weakness, distal groups. Lesion can be in the muscle or nerves, caused by early motor neuron disease, peripheral neuropathy, myotonic dystrophy, type 1. Findings: also we will not see upper motor neurons or sensory disturbance. Here is an excellent algorithmic approach to muscle weakness. So important points in history taking. History presenting illness should begin with open-ended questions, asking patient to describe in detail what are they experiencing as weakness. Then specific questions can be asked regarding motor function, for example, combing their hair, swallowing, rising from the chair, climbing, walking. And we should also ask the severity or the onset of the weakness. It is hyperacute, acute, subacute, or chronic. The past medical history is very important. When now in chronic illness, for example, hypertension, atherosclerosis, or diabetes, it suggests a vascular cause, for example, stroke. Or if the patient is now in case of migraine.
Recording in progress.
Migraine, patient can develop hemiplegic migraine, or if the patient is known as epilepsy, he could have a post-ictal weakness. Also, cancers such as, or any type of cancer can result in pulmonary cancer syndromes or Eaton-Lambert syndrome. Infections such as meningitis also is a risk factor or can cause strokes. Also, cardiac conditions such as AFib or any arrhythmias, the patient can develop stroke due to irregular heart rhythm. AFib can cause LV thrombus or LA thrombus. Also, family history of any neurological or hereditary disorders, such as MS or family history of strokes, can increase the chance for the patient to develop stroke. Social history, asking about illicit drug use, especially in young patients who take amphetamine or cocaine or any vasopressor or stimulant. Alcoholism also, for example, patients with cerebellar degeneration can be caused by alcoholism. Recent travel will suggest infectious process, occupation, or exposure to toxins. Risk factors are also important. We highlighted them before. Can be defined or separated as non-modifiable or modifiable. Non-modifiable such as age, sex, race, family history, genetic disorder, or modifiable, hypertension, diabetes, AFib, recent MI, dyslipidemia, smoking. Determining the onset of symptoms is very vital to differentiate or to have a differential diagnosis for diseases. Acute onset usually becomes severe within minutes or less. So from seconds to minutes, this can suggest stroke, migraine, or seizure. Subacute progresses steadily over hours to days, can be caused by transverse myelitis or GPS, usually post-infectious or post-surgery. Chronic progresses over weeks to months, can be caused by hereditary neuropathy, muscular dystrophy, or myasthenia gravis. In examination, we should examine the mental status of the patient, the appearance, sensorium, cognition, speech, thought process, thought content. Cranial nerves are important to differentiate brainstem lesions, and especially upper motor neuron. Motor examination, such as the muscle appearance, for example, atrophy, power tone, and reflexes. Sensory examination, such as tactile sense, proprioception, temperature sensation. Coordination, we examine finger to nose, heel to chin test, rub alternating movement. Gait, we examine the patient and ask them to walk, heel to toe, and thrown back test. Going back to history taking, ocular involvement, for example, asking about ptosis, diplopia, And one of the vital questions and important questions is to determine if it's monocular or binocular diplopia. Monocular diplopia usually goes with ophthalmological causes. Binocular usually neurological causes. Facial and bulbar involvement, difficulty swallowing, cough and choke while eating. This indicates brainstem or upper brainstem involvement. Neck muscles, head drop, difficulty raising the head of the fellow. Diaphragm weakness, decreased walking thrust due to shortness of breath, more than headache, usually indicates CO2 retention. Proximal upper extremity weakness, a task with the held above the shoulder, combing hair, distal upper extremity weakness, loss of hand dexterity, can't open the bottle of the water. Proximal lower extremities, difficulty when rising from the chair or floor. Distal lower extremity weakness, tripping over small obstacles, ankle sprain, foot drop. So after taking history and doing full neurological examination and general examination, we go to laboratory studies such as basic routine labs, CBC and chemistry, and thyroid function test, because thyroid function test can indicate myopathies, can cause myopathy, hypothyroidism can cause myopathies, urinalysis, and electrolytes, for example. Hypokalemia can also, or hyperkalemia, can cause weakness, usually flaccid lower limb weakness. ESR indicative of infection or inflammatory process. Serological test studies can also inform us regarding the HIV status of the patient, of the probability of having infection. Imaging studies, for example, any patient coming with right side weakness, we order urgently CT brain routine without contrast, or if there is an infectious cause or a chronic cause of weakness, we do MRI brain to rule out any structural lesions or meningitis, for example, or encephalitis. Electrophysiological studies such as nerve conduction studies and EMG are indicated the presence of myopathies or neuromuscular junction disorders. Echocardiogram ECG also is very important in patients with stroke to rule out cardioembolic source of strokes. ECG to see atrial fibrillation. Echocardiogram to rule out if there's any LV thrombus or LA thrombus. So finally we have a case. Ali is a 35 years old male, Saudi right-handed, known case of uncontrolled hypertension, diabetes, heavy smoker. Came to ER with sudden onset left side weakness that started 7 hours ago. When you came to assess him, you found upon examination that he has left side dense weakness, power of 0 out of 5, hypotonia, reflexes, +1 in the left side, plantar mutant left side. After seeing all this finding, is it upper motor neuron or lower motor neuron signs? مين يجاوب؟ طيب أغلب الناس قالوا لا موتور نيورون ليجن. هو أحيانا في الأكيوت سيتنج في الستروك تيجي بساينز كده تخدع الشخص، يعني يكونوا هايبوتونيك وريفلكسز هايبوريفلكسيك بلانتر ميوت. فبس الواحد لازم يجمع الهيستوري والاكزامينيشن يشوف يعني ايش الليجن اللي يكون لور موتور نيورون اللي حيجيب ليفت سايد ويكنس فشبه مستحيل. تمام. في الاكيوت سيتنج احيانا تكون مخادعة شوية، عشان كده هي يعني مع الوقت he will develop upper motor neuron lesion، بس by examination شكلها lower motor neuron examination. عشان كده مثلا في الاكيوت ستروك مثلا او ستروك كود ما نشوف ما نسوي الريفلكسز، ما نسوي اي من هذه الاشياء اصلا. يعني ان اتش سكور كله عباره عن الويكنس وكيف الدريفت قد ايش. تمام. نفس الشيء السباينال كورد ليجن في الاكيوت اونست يكون فلاسيد باراليسيس، فيجي كده بساينز وسيمتومز كأنها lower motor neuron lesion، بس هو عنده acute spinal cord lesion. ايه فهو يعتبر acute بس الساينز ما هي lower motor neuron lesion. يعني الواحد يجمع الهيستوري والاكزامينيشن ويطلع باستنتاج.
يا رب ما تشتغل.
تمام، جزاكم الله خير.
تمام، شكرا دكتور عمر، يعطيك العافية، ما قصرت. ونشكركم على حضوركم. طبعا الحين وقت الأسئلة، أي أحد يبي يسأل الدكتور موجود. طبعا في فوق مر سؤال. دكتور عمر موجود؟
ايه موجود.
ايوه، هنا في حد سأل يقول how can we differentiate between GPS variants in terms of presentation of symptoms.
ايش رايكم الاسئله اجمعها وبعدين اجاوبها؟ يعني ارسل لكم الاجابات.
تمام، ما عندك مشكلة دكتور عمر.